we joined the programme in 2013, around sort of September time was the first session that we ran. And this was the challenge that we put forward as our proposal, which was an integration of both physical and mental health, health and social care pathways to avoid inappropriate admissions. We'd been a system that had had a lot of transformational change, so we'd actually been on a programme around strategic change since 2007. We'd moved from 4 district general hospital sites down to 2. We were in the final throes of those changes, and during the programme we actually moved the last acute beds and A&E from one of the hospital sites in Welwyn Garden City up to the Lister Hospital site in Stevenage. So we would have less beds in the system. So there was a real focus on how do we make sure that the system is working effectively to avoid us having a bed crisis going forward. We had 5 of our 14 GP board members as part of the programme, senior colleagues within the CCG and senior colleagues within social care. And a lot of those had actually had changes in roles because they'd been going through quite a large restructuring. And this was very much the adult side of the County Council's social care services. One of the first things we had to do on the first session was we were given a whole table full of bits and pieces, and we had to create a collage around the vision and what we thought good looked like. My GP colleagues quite liked the theoretical side of things, but actually for them it was quite interesting, a different way of learning, and there were some real interesting discussions and conversations around some of the ways that the technology and the process of that learning we went through. And very much what we found the benefits of the programme was around that protected time for that learning. And we actually have some tangible outcomes from the programme that we were on. So we have early supported discharge in place. We have a virtual ward, integrated nursing, social care, mental health and voluntary sector called Home First. And we have one of the largest better care funds in the country. So if you look at what the highs were, I think it was actually a really enjoyable way of delivering training. The relationships we developed were very positive and they're being utilised. The time commitment was huge. We were expecting people to take days out over 6-7 months, and that was quite hard, especially for some of our GP colleagues. So we actually had to agree to backfill some of them. And how did we engage with providers? And we ended up doing that on an ad hoc basis, bringing them in for some things, but recognising, well, if we're commissioners and we want to look at how we're commissioning differently, do we actually want one of the providers that we actually want to do something different with in the room, and how do we square that circle? So that was some of the challenges we had. One of the most powerful sessions we had was the storytelling and the story of self, the story of now and the story of us. And that was really resonated with a lot of us. You could have heard a pin drop when one of our GPs related the story of self. And it has been used by a number of our GP colleagues especially in getting their GP colleagues on board around the primary care strategy and why things should be different and why putting patients at the heart of what we do in a different way can have real benefit. The driver diagram that was mentioned earlier, ours was huge, and this was only one of 3 that we did. It ended up on a wall with rolls of wallpaper effectively, and post-its and string. And then Jenny and I were able to translate this into something more simplistic. But this, if you like, was the original brain dump that we had in one of our sessions, just looking at if we wanted to improve people dying in their preferred place of death, what did we need to think about? And the creativity and ideas that came forward, things like talking to funeral providers in terms of some of their funeral plans, and how does advanced care planning fit into some of the discussions that they might have. One of the other tools that we've used significantly since has been statistical process controls. What we recognise is we had a plethora of data, but we weren't really skilled in understanding it, and what the level of granularity you needed to have in terms of your data to be able to understand where change has impacted on what you're doing. And we use these very regularly now in terms of how we look at the effect of some of the changes that we're implementing. One of the things that we really worked on, and I think resonated with people, was agreeing that shared purpose. And part of the work we also had to do was look at shared language. So we had a quiz. So we had social care colleagues on one side of the room, health and care colleagues on the other side of the room, and it was a quiz around acronyms. And none of them could get the others at 10 out of 10. So it really made us think about our language. So there's a real mismatch between actually the risks and the care plans that you put around that person if you describe them as frail in a hospital or you describe them in GP land. And we need to get better and smarter at how we do things. Part of what we've done is, in terms of our Home First, is the co-location of health and social care colleagues, adding in mental health, adding in the voluntary sector who can help signpost to other services. And that's been a real key benefit to it, because you can then understand each other. You actually can have the conversation around Mrs. Jones and what does she need. It did feel like speed dating at some points, but it was really useful to be able to have those conversations and to get to know different colleagues and to be able to have those corridor conversations or be able to pick up the phone knowing who that person was on the other end of the telephone. These were personal insights that some of the Alliance team said, and it was around relationships was a huge amount, but the importance of that time out to be able to do this, and we don't give ourselves permission to do this as often as I think we ought to do. Those 8, 6, 7 sessions that we had, actually the benefit of them and the investment in that time and the added value, I think has been quantifiable in terms of the confidence that GP board members have to be able to take things forward, but also in terms of our ability to, because we have that shared vision, that shared language, it's quicker to get things moving in terms of how do we take forward equipment when there's a problem. You pick up the phone, you know who you're talking to, you're able to take things forward. So just in terms of some of the work we did and how we're taking things forward, we are looking at how we work together to jointly commission home care and care in homes. So we've got a Vanguard project bid that we've put forward around a programme of work to support care homes. We've also got GP practices aligned to care homes. We've got all of our GP practices going on to System 1 so that we've got that interoperability. All of those things were starting to be looked at, but because we've got GPs who get it in terms of shared vision, shared understanding, it's enabled some of that work to happen at a higher pace. Our primary care strategy has been built on this integration, and what does that mean at a locality level? Bringing social care colleagues into practice meetings, but also into our Home First pilot has been of real benefit, but then recognising the voluntary sector and mental health into that as well. So a lot of the work is already in train, and we just feel that there's more that we can be doing.